Sasa hao wa massage wale wa kunyorosa hiyo tumbo na kuweka mtoto kwa laini wananitembelea kwa nyumba, ama ananiita kwake asubuhi mapema kabla hajakula ndio nijue hali ya mtoto vile iko kwa tumbo.
Unatumia nini kufanya massage?
Ndio nachukuanga na warm water, maji moto, na chamusa, na mlalisha mahali pasafi, naanza kumasaji nikipima, nikichunguza mahali iko kasoro kwa tumbo, na nyorosa kabisa na masaji kabisa. Anakuja laini baada ya siku 3, hiyo kitu ilikuwa inashika mguu inawacha kama kwa mbavu, anakuwa sasa anapumua vizuri.
The challenge of maternal health in Kenya and broadly in Africa and in the developing world is one of lack of access, lack of qualified personnel, and also lack of technology that would be relevant to this region. In the rural setting, the biggest challenge of maternal child health is access in terms of the distances that people have to travel, lack of transport, lack of facilities like having electricity. Then of course, personnel, people do not want, especially qualified medical personnel, do not want to live in the rural areas. The Nairobi Women's Hospital started in the year 2001. The numbers have ramped up. Currently, we attend to more than 10,000 every month. The demand for maternal child health since 2001 to 2015, where we are today, has tremendously increased. The Nairobi Women's Hospital started in the year 2001. We got together as a group of doctors. I was leading them, and the vision was to start as a specialized hospital. And when we got started, we didn't have an idea how big this was going to be. We started with only 50 beds. Now we have 277 beds in 5 different locations, not only within Nairobi, but in 2 other counties, Kajiado and Nakuru counties of this country. Currently, our occupancies are 80-90% most of the time. Clinics are full. So we have grown to be the largest private for-profit hospital chain in Eastern Central Africa. Oh, the challenges have been many, but just to mention a few. One is lack of personnel. And when I say personnel, I don't mean just getting a nurse. It's lack of getting a nurse who understands the model of what we want to do, both from a quality perspective and from a business perspective. Generally, having to retain medical staff has been very, very challenging, especially doctors, where you find doctors do not want to work in this country, and then the doctors are moving to the Western world where there are better terms and also opportunities for training. The next challenge that we have faced over time is the challenge of supplies, both pharmaceuticals and medical equipment. Now, on the pharmaceuticals, one of the biggest problems we've had, not only in Kenya, but in Africa, is the problem of counterfeit. Medical equipment is generally expensive. So there are no technologies that currently address or can be used to deliver the same quality but be affordable for the kind of setup that we have. How we overcome the challenge of getting good personnel? One has been to be very thorough in our recruitment. Of course, then we are forced to offer better terms. But even after we offer better terms, before we started our medical training college, we also took them through very intensive induction and orientation processes. So when we developed our strategy, we completely engaged our staff. And then that engagement has helped us retain staff, even when we have had very serious cash flow problems, that people are proud to work for the Nairobi Women's Hospital because of the results and the impact that we are having in the communities. So everybody is here. It's not just about the job. It's beyond the job. How do I feel? And then also, how are you treated at the workplace? So the manager, supervisor, and everybody else relationship, how does that play out? So we took that which I would call our competitive advantage from money to engagement. We have a very rigorous quality assurance program at the Nairobi Women's Hospital. Indeed, we have a board committee that looks at quality. And that board committee the secretary is the chief of clinical services, and we actually have a quality officer, and we monitor quality through various parameters. And this is one of the things that are reported during the board meetings. And not only from the board, at the senior leadership meetings, there's an aspect of quality that is reported. At the management meetings, at the unit branch level, each hospital meeting, there's reporting on quality, and that goes all the way to the department. There are dashboards that I'm able to get information, so that then they can be refined to give me certain data. For example, every morning I'm able to get data about all the outpatient numbers that were seen the previous day. I'm able to see all the admissions that were done in each of the branches. I'm able to see all the discharges, and therefore I'm able to work out how many patients we have in the wards. Then I get also a report on mortality and morbidities every day. I'm also able to get revenue reports every day through SMS on my phone. We get patient feedback through various ways. Once we get the feedback from the patients, we then put this into a system, and then our customer relations officers are able to analyze this data per day, per branch, and we analyze various aspects of our services, ranging from the nursing care to the doctors to the food to the ambience of the environment. The Nairobi Women's Hospital has not even scratched the surface. Our vision is to provide healthcare to women in Africa. In fact, our statement is that we are trusted with the healthcare of our women in Africa. It means that we are putting a responsibility on our shoulders, that right now as we speak during this interview, if a woman has died in Ethiopia, it was my responsibility to have saved that life. I am very cognizant of the constraints and the demands of what that means. The vision is big and there's work to be done. So we'll not only expand to the urban areas, we also plan to expand to the rural areas. And collaborating with other people, we can be able to have clinics across Africa. We can be able to have hospitals at tertiary level which can act as referrals, creating a hub and spoke model where people are able to access services, basic antenatal and basic clinical services, and then those who need to be referred then go to the tertiary hospitals. And we are very keen to make sure that we can roll this out throughout Africa. One of the biggest challenges of healthcare, and not just in Kenya or Africa, worldwide, is the cost of healthcare. Healthcare is expensive, and especially good healthcare. And though it's debatable whether quality is expensive, without semantics, there has to be a cost. So how we intend to bring down the cost of healthcare is, number one, is by negotiations. We've already done that by being the largest private for-profit network of hospitals in East and Central Africa. I'm able to walk into any of the manufacturers and negotiate a good price for my supplies. The second one is then also getting people not necessarily pay out of pocket. There has been a huge shift now to push people in Kenya and in many other parts of Africa to have health insurance, because out-of-pocket expenses can end up being catastrophic. The rural areas pose a challenge in terms of provision of services, especially from a private sector perspective, in that the rural areas are not always profitable in terms of monetary returns. You find that most of the investors, even social impact investors, will look for some form of return. So we are looking at another model that is a low cost model that operates on a hub and spoke, where we have network of clinics using telemedicine, then are connected to the hub, and we can then be able to offer consultation to the clinics, specialist consultation. So for example, you have an obstetrician sitting at the hub, and the spokes are able to connect with that one obstetrician servicing a wider population. So what are you doing? We are using an expensive resource to provide services to more people. And if it was physical contact, then it will not be possible. So we are leveraging on technology. And then those spokes will have low-cost devices, And these low-cost devices then are connected directly through telemedicine to the hub. Now, what happens is that if there is then a complication, then there is transfer of the patient from the spoke to the hub. This is a model that we are going to be rolling out soon to see how then we can be able to expand it, because we do believe this is going to be the solution for delivery of maternal child health care, not only in this country, in Africa, but in many other low resource setups. So we cannot negate technology at any one time. So we are not saying that because it's a rural setup, we go back on technology. That will not help. In fact, it's leapfrogging in technology that's going to help solve the healthcare delivery systems for the rural areas. So it's not going back on technology, it's leapfrogging and getting new technologies.